You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for March 12th, 2021. This week, COVID, heart failure, DOACs and surgical valves, Medicare spending in the pandemic. This week marked the one-year anniversary of the pandemic. I was talking with my granddaughter, a second grader. She was very excited about going back to school next week. I thought to myself how my memories of first and second grade seemed like a blur, but surely she will remember this past year forever. We all will. The slope of the falling hospitalization curve here in the U.S. is shocking in its degree, and it is such good news. Locally here in Louisville, we have only 20 patients with COVID in our hospital. This is lower than even the low summer numbers. And a larger hospital system in our city sent an email to employees proclaiming the number of patients with COVID who are on vents as 0. Imagine that. But as I learned from Twitter this week, the pandemic isn't quite so over everywhere. As it has always been, COVID remains a regional issue. While Kentucky and Indiana and West Virginia seem to be doing very well, some places are still struggling. New York, for instance, and I wonder why the cases have plateaued there. And my friends in Brazil talk of serious stress from rising COVID cases, and my thoughts are with them. A study showing real-world data from the Israeli experience of rapid vaccination, however, confirms super high efficacy of the vaccines, and again, this is really promising news. The challenge, of course, is just getting these vaccines out as quickly as possible. Next topic is heart failure. This week, a multi-specialty international group of 38 authors has proposed a new universal definition of heart failure. They have made major revisions to the staging and classification of this condition. The Journal of Cardiac Failure and the European Journal of Heart Failure published a comprehensive document. I will likely mispronounce the lead author. It is Professor Bikram Bozkurt from Baylor. Doctors Antman and Brunwald wrote an accompanying editorial. But before I go into the details of this massive document, it is useful to reflect on the term heart failure. Here, I have to cite the now retired British GP, Dr. Richard Lehman, who is one of the wisest clinicians I've ever learned from. An aside is that in the early years of this podcast, I would cheat by reading Lehman's weekly journal reviews on the BMJ, which came out every Monday. In fact, this pod is an attempt to be a fraction as good as those gems. In 2005, Lehman penned an editorial in the BMJ calling for a new name for heart failure. He proposed the term cardiac impairment, and he noted that the term heart failure confuses clinicians and it scares patients. Indeed, I often actively refrain from using that term with patients. Recall that the word heart denotes not merely an organ, but also an innermost part of something, a courage, an enthusiasm, as in, this patient has a ton of heart. So when you combine the word failure with these meanings of heart, you do a lot of harm. But it's even worse than that, explains Lehman in his lead paragraph of that 2005 essay. Here he cites the great Jeffrey Rose. Quote, "There is no disease that you either have or don't have, except perhaps sudden death or rabies. All other diseases you either have a little of or a lot of. And everyone can have a bit of heart failure if they try hard enough, by physical exertion or even emotional shock." In that amazing first paragraph, Lehman also summed up the background info for this new effort to redefine heart failure. He wrote, because of widely varying definitions, the epidemiology of heart failure can become almost uninterpretable. with estimates of its prevalence in the United Kingdom that can vary from 500,000 all the way up to 3 million. Now, any clinician knows this well. I mean, you can get labeled as having heart failure for like 100 things. A patient with obesity who's dyspneic. You can have an echo during rapidly conducting AFib that shows LV dysfunction. This is a common thing I see. Then there is just simply having high blood pressure and eating too much salt and then needing a dose of diuretic. So the effort to sort all this out with better definitions is laudable. Now let's talk about this document. There are three main focuses of the paper. The first is just a good general discussion of heart failure. They summarize things like cardiomyopathy in heart failure. And the teaser is that cardiomyopathy is heart muscle disease, but heart failure is a clinical syndrome. The authors also mention competing diagnoses with heart failure. This is such an important thing. I wish that section was even a little longer. There's a nice distinction, too, that they make about renal failure, liver failure, morbid obesity with edema, and chronic respiratory failure with hypoventilation. These may present with symptoms and signs that mimic heart failure, but are not heart failure. And this comes up a lot, the authors tell us, in clinical trial adjudication of events. For instance, a patient has what looks like heart failure, but it resolves with hemodialysis. This is not heart failure. The second part of the document is proposed revision and stages of heart failure. Now, we've previously known these by various different names. By functional class, there's the New York Heart Association 1 through 4. By EF, there's HFpEF and HFrEF. Or by etiology, there's ischemic cardiomyopathy, non-ischemic cardiomyopathy. Or the ACC-AHA format by disease progression, which is stages A through D. And of course, all of these are fraught in some way. I mean, the New York Heart Association functional class is ridiculously fluid. Take this example. A doctor has a Medicare-age patient with a really worrisome non-ischemic cardiomyopathy, an EF of 25%. Let's say this patient initially reports no dyspnea or shortness of air, and the first note in the chart says Class 1. Well, it's now complete fraud to put in an ICD in the United States. But another doc who sees the same patient can simply press this person on getting short of breath with exertion, say stairs or inclines or whatever. As Lehman writes, anyone is dyspneic with enough exertion. Boom. Now that patient is class 2 heart failure and an ICD is allowed. So definitely a fluid distinction. In the end, the authors settled on the ACC-AHA stage A through D format with modifications. First, at risk for heart failure, that's stage A. This is for patients at risk for heart failure but without current or prior symptoms of heart failure, and they don't have any structural evidence of heart disease. Second stage is pre-heart failure, stage B, for patients without current or prior symptoms of heart failure but evidence of structural heart disease or some abnormal cardiac function and an elevated BNP. Stage 3 is just heart failure for patients with current or prior symptoms and signs of heart failure that's caused by actual structural or functional cardiac abnormalities. And the fourth stage, advanced heart failure, stage D. And of course, these are patients with severe symptoms, recurrent hospitalizations despite guideline-directed medical therapy, etc. Now, the document also changes the dichotomization of heart failure by preserved or reduced EF. So now, instead of just HFrEF and HFpEF, there's 4. First is heart failure with reduced EF. This is an LV ejection fraction below 40%. Second category, heart failure with mildly reduced ejection fraction, and this is EF between 41 and 49%. Third is heart failure with preserved ejection fraction. This is an EF better than 50. And then there's a new category, fourth category, heart failure with improved EF. And this is when the heart failure has a baseline EF of 40% or less and an increase of at least 10 points from baseline and a second measurement where the EF is greater than 40%. You'll notice that the two main new categories are mildly reduced category and the improved category. First, the mildly reduced. The authors waste no time in their discussion of this category in citing both the subgroup analysis of Paragon-HF, which found benefit in a composite endpoint of heart failure and CV death in patients with EFs below the median of 57%, as well as they also cite the post hoc combination of Paragon and Paradigm, showing that there was a continuum of benefit correlating with lower and lower ejection fractions to a certain point. But they also mention A, the potential overlap in this group, B, the challenge of using echo to determine EF, and C, the fact that people can easily move in and out of the minimally reduced groups. Now, as for the improved category, the authors make the case that this category may help prevent discontinuation of meds in people with recovered EFs, aka they still have heart failure, so they should stay on their meds. Lead author Dr. Boskert stressed that heart failure with improved EF only applies if the EF improves to above 40%. A move of an EF from 10 to 20% would still see that patient classified as having heart failure with reduced ejection fraction. But a patient whose EF improved from, say, 30% to 45% would be classified as heart failure with improved EF. Now, to encourage further discussion and acceptance of this document, the editors of the Journal of Cardiac Failure said that we'll publish many explanatory perspective pieces starting in May. Couple comments. While I hate the term heart failure, I know it's entrenched and it's here to stay. The current nomenclature of heart failure is terrible, so good, we need to work on new ways of sorting through this. But this is a complicated schema. It's certainly going to evolve, and I think that's fine. Keep in mind that the universal definition of MI took some work as well. Likely, we'll be talking more about this on future podcasts. 3 quick thoughts, though, about this. First, I worry about categories of ways to define not having heart failure. As I've said before, not dying young is a good way to be at risk of heart failure or have pre-heart failure. Now, I understand the author's point, though. For instance, patients with LVH due to hypertension would have a less chance of getting future heart failure with good blood pressure control and counseling on diet and exercise. And patients with diabetes and chronic kidney disease clearly have less heart failure chances with SGLT2 inhibitors, and having a category of pre-heart failure may help more patients receive these beneficial drugs. I often cringe when I see diabetic patients on 3 drugs and one of them isn't an SGLT2 inhibitor. Now, second point, I also understand the heart failure with mildly reduced ejection fraction problem. These patients aren't exactly HFpEF and they aren't exactly HFrEF. But I'll try to suppress that little voice in my head that says, this category seems like a way to advance the use of the expensive drug sacubitril valsartan. As I have also discussed, this indication is problematic because it is based on a subgroup analysis of one trial, Paragon-HF, that had a non-significant primary endpoint and no signal of CV death reduction. In a better world, FDA would have sent Novartis back to the drawing board to do a trial in the subgroups that looked promising, as in subgroups are exploratory for the purposes of generating hypotheses for future trials. Third point, even if you love these definitions, the confusion will remain in American hospitals because clinicians here still have to code according to the wholly different and anachronistic scheme of acute and chronic systolic or diastolic heart failure. Maybe someday coding will align with clinical diagnosis, and I think that would do a lot to organize thinking around heart failure. Next topic is direct-acting oral anticoagulants, DOACs, after heart surgery. A group of researchers from Cleveland Clinic, led by Dr. Ankur Kaura, published a research letter on the use of DOACs in patients who had surgical valve replacements. They used data from the STS registry. Now, whenever you hear the term registry, remember Surgeon Joseph Bavaria's comment. Science tells us what we can do, trials tell us what we should do, registries show what we are actually doing, and that is about it. So, patients who underwent surgical aortic valve or mitral valve replacement with either a mechanical or bioprosthetic heart valves between July 2014 and June 2017 were included. This was 177,000 patients. About 1% of patients who had mechanical valves and 1% who had mitral mechanicals were on DOACs at discharge. That percent did not change over time. Approximately 5 to 6% of those who had bioprosthetic aortic and mitral valves were on DOACs at discharge. And for bioprosthetic valves, the use of DOACs seemed to increase over that 3-year period. We don't know for certain, but we assume most of the oral anticoagulation use in bioprosthetic valves were for AFib or perhaps VTE-PE. I highlight this study because the authors seem to think the increasing use of DOACs in surgical valves is a bad thing. And it definitely is for patients who have mechanical valves. Realign was an RCT of dabigatran versus warfarin in patients with mechanical valves, and it was stopped for harm in the dabigatran arm. Cardiovascular trialist Dr. David Cohen noted in a news story that this very low amount of 1% could be simply due to coding error. But the title of this study includes the term off-label, and the authors conclude our study suggests a prevailing off-label use of DOACs in patients with prosthetic heart valves without satisfactory safety data. I don't agree with the idea that we have to withhold a more convenient anticoagulant, at least when AF is the indication. Consider that in 2019, the ACC guidelines for AFib clarified valvular versus non-valvular AF. Non-valvular AF, they wrote, does not imply the absence of valvular heart disease. And valvular AF was narrowly defined as associated with mechanical valve replacement or severe rheumatic mitral stenosis. Everything else was non-valvular, including bioprosthetic valves. And then a year later, in 2020, a joint consensus document from the European Heart Rhythm Association that was okayed by many different societies reiterated the ACC guidelines that valvular AF is outdated and proposed a functional ERA categorization in relation to the type of oral anticoagulation use in patients with AFib. For instance, ERA type 1 refers to AF patients with valvular heart disease that needs therapy with a VKA antagonist, warfarin mostly. These were mitral stenosis patients, rheumatic origin, and mechanical prosthetic valve replacement. ERA type 2 included everything else, and warfarin or DOACs were acceptable. Now, of course, I would never just cite guidelines. I'll link to a meta-analysis for DOAC use in about 1,400 patients with AFib and bioprosthetic valves in the pivotal DOAC versus warfarin trials. This study found similar efficacy and mostly similar safety with warfarin or DOACs in patients with these bioprosthetic valves. So in sum, yes, there is not a formal indication for DOAC use post-tissue valve. And yes, it would be nice to have an RCT. It would be nice to have RCTs for everything. But right now, with the data that we have, and more than a decade-long experience with the DOAC drug class, I think it is very reasonable to choose DOACs when anticoagulation is felt suitable after a bioprosthetic valve. The harder question, I think, is the broader one, is when should anticoagulation be used in these post-op patients? Okay, final topic, briefly. Physician spending during the pandemic. Get this. The AMA recently put out an economic analysis that found spending on physician services fell 40% between January and April of 2020. The absolute number of how much less is eye-catching. Medicare paid docs $9.4 billion less in the first 6 months of 2020 than historical norms. Now, among physician specialties, the cumulative reduction in spending over this time dropped only 6% for nephrology, dropped 14% for internal medicine, 16% for family medicine, and 19% for cardiology. Now, I can see how nephrologists would go down the least because dialysis can't stop, but I highlight this data because I found it remarkable that Medicare paid cardiologists 20% less during that 6-month period. Now, cardiologists care for heart disease, and heart disease is a leading killer. If your heart stops, you're a goner. Given the necessity of heart function, 20% less cardiology services seems like it would be a calamity. So the questions that I hope you are wondering about are these. A, did this lead to worse outcomes? And B, how much extra low-value care do we actually deliver? Now, of course, those of you who think cardiologists exert godlike control over many things health-related, you're going to cite the observational studies from the pandemic that found higher rates of in-hospital mortality from acute MI because patients presented later. Maybe. But these sorts of ecological studies are hard to make causal conclusions from, and it is just one diagnosis, AMI. For weeks and months during the spring and summer of the pandemic, our nuclear cameras and echo machines literally gathered dust. Our cath lab did only acute PCI for ACS syndromes. We in the EP lab did pacers for heart block and ablated only incessant tachycardias. In other words, we did only the necessary work. And I have no doubt that chronic disease management is important, but the question is, How much exactly did the heart health of our patients suffer when we were paid $9.4 billion less? I think this will be a question of much further study going forward, but I hope we are brave enough to look at this natural experiment as an opportunity to assess the amount of low-value care we deliver. If the delta, the difference between how much you produced in 2020 is way less than it was in 2019, there are two possibilities. You did too little in 2020, or you did too much in 2019. I think it's something to think about. You all know where my bet lies. So that's it for this week in cardiology. As always, I am grateful that you listened. Thank you. And remember, if you like this podcast, please take the time to give us a rating, write us a brief review. It really helps others find us that way. Until next week, this is John Mandrola from the Heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.